everyone. My name is Jin Ho Kim. So I'm a radiation oncologist in Seoul National University Hospital. So I'm quite honored to moderate this webinar tonight. So today's topic is about the carbon iron treatment for prostate cancer contributed by my dear colleague, Dr. Lee from Yonsei University. Before we start, we have greetings from to our chairman of two societies. So, okay, so first, is Dr. Angela online?
Yes.
Yes, please.
Okay, thank you. Hello, everyone, distinguished speakers, FARO officers, FARO advisory board and council members, and also friends and colleagues and FARO participants. Good afternoon, good evening to all of you. I'm Dr. Angela Giselvania, Treasurer of FARO, and I'm honored to represent the Federations of Asian Organizations for Radiation Oncology, FARO, as we open this special webinar on carbon ion therapy for prostate cancer, hosted by KOSRO and supported by IRORA. We are honored to bring together some respected experts in the field of radiation oncology, and today we will learn more about carbon ion therapy, a new and advanced type of radiotherapy that shows great promise in treating prostate cancer. Let me begin with expressing our sincere gratitude to Dr. Chul, the president of Korean Society of Radiation Oncology, for his support in making this event possible, and also to our keynote speaker, Dr. Chan Woo-wee, and Dr. Jin Ho Kim, who will guide us as the moderator of this event. And also special thanks goes to our distinguished panelists, Dr. Sung Uk Lee, Dr. Masahiro Onishi, and Prof. Kim Shang, who will bring their valuable insights from Korea, Japan, and China. This webinar is not just for sharing knowledge and experience, but also a chance for us to work together across countries to improve cancer treatment, especially in Asia. Thank you again, everybody, for joining here. I hope you all enjoy the session, and let us begin. Thank you.
Thank you, Dr. Giselvania. Thank you for your kind remarks. So next, we have Dr. Chul, the chairperson of KOSRO itself. So please, Dr. Park.
Yeah. Hello, everyone. This is Chul Park. Welcome to FARO webinar of April, hosted by KOSRO. And it's great privilege for me to address the welcome message today. As all of you already know, the aim of FARO is to foster the role of radiation oncology and enhance the fundamental level of radiation therapy for the benefit of cancer patients in the Asian region. Since the establishment of FARO, its main activities have consistently focused on academic advancement in FARO member countries. Taking this opportunity to host this 33rd FARO webinar, I would like to express my sincere gratitude to the Education and Training Committee for their dedicated effort in making this event possible. The subject of this webinar is carbon ion therapy for prostate cancer. Particle therapy actually has recently been expanding its role within the field of radiation oncology, with its application growing continuously. Currently, there are 2 operational proton therapy centers and 1 carbon ion therapy center in Korea, and with several additional institutions preparing to adopt particle therapy in the near future. So notably, 2 more institutions are actively developing a new carbon ion therapy project. Given this context, the topic of this webinar is especially timely and is expected to provide valuable insights and inspiration for FARO member countries. Lastly, I would like to thank our corporate member for their invaluable support. Please enjoy today's topic, and thank you very much. Thank you.
Thank you, Dr. Park. So before we begin the presentation, we trying to take a group photo first. So, okay. Could you do the group photo for me?
Okay, dear respected Prof and Doctor. My name is Ika from Indonesian Radiation Oncology Resident Association. First, I would like to thank you for joining our webinar today. Now, I will assist you in taking our group photos. The picture will be taken twice, so kindly turn on your camera and please hold still for a brief second so we can get a clearer picture. Okay, 1, 2, 3, smile. And once more, 1, 2, 3, cheese. Okay, back to you, Dr. Jin.
Okay, so we have greetings from prominent doctors, and the group picture was done. So it's time to begin our main event. So I'm quite honored to introduce today's speaker, Dr. Chan Wee. Dr. Wee has been my longtime colleague in my institution, Seoul National, and he now has moved to Yonsei University, and he's in charge of carbon ion treatment for the prostate cancer, and he's very actively involved in clinical practice and research development in the genitourinary cancer in Korea. So Dr. Chan Wee will cover the broad topic regarding the application of carbon ion treatment for prostate cancer. So Dr. Chan Wee, please.
Thank you for your kind introduction, Professor Kim. And as he introduced me, he was a longtime senior colleague, of course, now as well. And thank you for the FARO and KOSRO organizers to invite me in this honorable webinar. And actually, it is an honor for me to represent KOSRO in this webinar. And actually, my wife gave birth to our first child last week, so this is my first talk as a father, so I think it's more meaningful. And today, I'll talk about carbon ion therapy for prostate cancer. And I think I might not be the most experienced one, even in our institution. And of course, I think some of the audience have more experience in carbon ion therapy for prostate cancer compared to myself, but I'll just go and review the current evidence and the protocols that we are using in our Yonsei Cancer Center. So I'm Chan Wee from Department of Radiation Oncology, Yonsei Cancer Center, and I'll first share my slides. Can you see my slides?
Yes.
Okay. So I have no disclosures, and these are my contents. I'll first introduce the carbon ion therapy facility in our institution, Yonsei Cancer Center, and some of the rationales for using carbon ion therapy for prostate cancer, and some of the data on clinical outcomes of carbon ion therapy and the Yonsei Cancer Center protocol for prostate cancer, and some more things we have to consider moving forward. So before the introduction, I think before we dive in, let me start by bragging a little bit about Korea. And some of you might be familiar that Korea is one of the powerhouses in archery and shooting and fencing. And in this context, I think it's fair to call Koreans and Asians sharpshooters. And about 10 years ago, Nature has called out charged particles as sharpshooters, which include carbon ion therapy. So Seoul is a very large city. It almost half of the Korean population live in the Seoul metropolitan area. And as President Park introduced that we have two proton therapy centers. One is the National Cancer Center, which have been treating patients since 2007, and Samsung Medical Center, which have been open since 2015, and one heavy ion therapy center, which we have the carbon ion therapy. We have 3 treatment rooms, and the Yonsei Cancer Center has been treating patients since 2 years ago. And there are more than 100 radiation therapy machines in the Seoul metropolitan area. So this is a photo of my institution. The building on the left is the Yonsei Cancer Center, and the building on the right is the main Severance Hospital. So Yonsei Cancer Center Radiation Oncology Department has been one of the pioneers in radiation oncology in South Korea. And in 2023, we have treated over 8,000 cancer patients with radiation therapy. And we have almost about 400 treatment patients per day. We have 8 Linacs, 4 Tomos, 1 CyberKnife, 1 ICR, and 4 CT simulators and 1 MR simulator. And for carbon ion therapy, we have 1 fixed beam treatment room and 2 gantries. So this carbon ion therapy project in Yonsei has started about almost 12 years ago. And of course, during the period, we have signed some MOUs with well-known carbon ion centers across Japan, including QST, Yamagata, Kanagawa, and Gunma. And we had our staffs been trained in those centers during the period. And we have completed our heavy ion treatment system installation in 2022, sorry. So this is how the center looks like currently, and we have 5 floors below the ground and 7 floors above the ground, and the treatment facility is mainly in the below the ground, and the 7 stories above the ground is used as offices, and on the 4th floor, which I am sitting, is the radiation oncology department. So I think everybody here knows about the brief history about charged particle therapy, and the Nobel Prize winner Sir William Bragg has found out that there is a phenomenon called Bragg peak in charged particles, and Dr. Robert Wilson from US has recommended using these Bragg peak for cancer treatment. And the world's first proton therapy was done in Lawrence Berkeley lab in 1954. And since then, the Lawrence Berkeley lab has used neon and carbon as for cancer patients. But I think it had the world's first carbon ion therapy system that has been dedicated to cancer treatment is the NIRS, which is the QST hospital now, and they have been treating cancer patients since 1994. And since then, a lot of several countries in Europe and Asia have installed carbon ion therapy in their institutions. And 2 years ago, the first carbon ion arrived in Korea in Yonsei Cancer Center. So we were the 15th institution to use carbon ion therapy, and there are 2 more large centers in Korea that have completed the contract for installing the carbon ion therapy. So this is a photo of our center. The one in the above left is the accelerator, and the one in the above right is the fixed beam treatment room, and the lower left is the gantry treatment room, and lower right is the actual gantry and the superconducting magnet you can see behind the gantry treatment room. So 2 years ago, we have successfully treated the first localized prostate cancer patients with carbon ion. And since then, until last week, we have completed a treatment of over 500 localized prostate cancer patients in our institution. So then, what are the rationales for carbon ion therapy for prostate cancer? So worldwide, it is the second most common cancer in men and the fifth leading cause of cancer in men. And in Korea, the incidence of prostate cancer is really gradually rising, and it is estimated to be the leading cancer incidental-wise by 2024, 2025. And at diagnosis, most of the patients have localized disease, or some patients, near 10 to 15%, will have regional lymph node metastases. So the local treatment is really, really important. And you can see that the prostate cancer incidence is gradually rising in Korea, and probably this will be the case in most of the Asian countries, similar to the Western countries in the future. So we know that we have a very special treatment option for prostate cancer patients, which is active monitoring, which you can call active surveillance, which is not normally used for other cancers. And we have to discuss this option with almost nearly all patients we meet in the clinic as a radiation oncologist. But other than those patients, in nearly every risk group for localized prostate cancer, and even in node-positive prostate cancer, and nowadays in metastatic prostate cancer, radiation therapy plays a really, really important role for treating these patients. And there is also, of course, a never-ending debate between prostatectomy and radiation therapy, which is better in survival-wise or local control. And some studies have shown that surgery is better than radiation therapy, but we have to consider the selection bias, because in the left, you can see that prostate cancer patient treated with EBRT has higher mortality than active surveillance. And from the SEER database, prostate cancer patients treated by prostatectomy have a higher survival than patients with no cancer. So probably our colleague urologists have done a really, really good job in selecting the most optimal patients who have to undergo surgery. But comparing the outcomes of radiation therapy and surgery should be done with caution. And this is a data from Sweden, including 40,000 prostate cancer patients, that if you perform a full adjustment considering the age and comorbidities and T stage, N stage, M stage, then in low, intermediate, and high risk, there is actually no significant difference regarding mortality between prostatectomy and radiotherapy. So we have more evidence now that SBRT can be better compared to surgery in terms of incontinence and sexual performance. And since we are in the hypofractionation era, which we are gradually shortening the treatment period, and we have the hypo-RT-PC data that has shown that ultra hypofractionation with 7 fractions is comparable to conventional fractionation. And we have the PACE-B data that SABR is also non-inferior to conventional or moderate hypofractionated EBRT. But we know even we give very large doses with a radiosurgery like SBRT or SABR. This is a data from Memorial Sloan Kettering that a significant portion of patients still have prostate cancer cells in biopsy, which when performed after SBRT, and you can see that if the dose goes up, then the cancer cells go down. So I think it's really important to know how that if we give more, then we of course can kill more and more cancer cells, but it all depends on the technology and of course the toxicity. So now about 80 gray is considered the standard for prostate cancer, and this is kind of an old data, but it has shown that 5-year biochemical control keep going up when you give more doses to the prostate cancer, and it plateaus after about EQD2 of 90 gray. So then, of course, prostate cancer is really treated well with conventional radiotherapy, X-rays, but then what additional advantages can we get with using particle therapy, especially carbon ion? So I think you are all familiar of these 5 characteristics of particle therapy or carbon ions. So of course you are familiar with the Bragg peaks, so we can give lower dose to around the tumor with using charged particles. And one important thing is that carbon ions have a very narrow radiation penumbra. So even compared to X-rays or protons, carbon ion has a very sharp penumbra. And this is a really simple comparison of a proton treatment planning and carbon planning for prostate cancer. And you can see even proton therapy has a very precise dose distribution. Carbon ion can be slightly better. And of course, regarding the biological aspects of carbon ion, since they are they have higher LET, then and it translates to higher relative biological effectiveness. So when you say the X-ray is 1, then proton has a 10% higher, and carbon ion is considered to be double or triple higher in terms of biological effectiveness. And of course, carbon ion have a lower oxygen dependency compared to X-ray or proton. And of course, they have a lower cell cycle dependency since they have a very high LET. So these might be some of the rationales of using carbon ion for cancer treatment. And we know that we can treat prostate cancer with so much ways, including the Da Vinci robotic prostatectomy, of course, brachytherapy, and of course, we have experienced very high biochemical control using IMRT with using protons or X-rays. So then, since prostate cancer is really treated well with other treatment options, then what can carbon ion give more for those patients? And although the prostate cancer is normally treated very well, still they have a lot of it's been reported that there is still a significant portion of hypoxic cells in prostate cancer, and those patients with those hypoxic cells tend to recur more after radiation therapy. And as you all know, prostate cancer is a very slow growing cancer. So probably a large amount of cancer cells might be in the somewhat radio resistant phase in the cell cycle, not the G2M phase or not the G2M phase. So in this context, carbon ion can give some more potential benefit for prostate cancer. And this is a data from Gunma University that shows that the dose to the rectum, which is the most concerned organ at risk when you do radiotherapy for prostate cancer, you can see that the dose is much lower compared to IMRT using carbon ion therapy to the rectum. And everybody might be aware that it is very difficult to perform a randomized trial between X-ray and proton, or X-ray and carbon, or carbon and proton, which leads to more difficult decision making to choose the treatment option for prostate cancer patients. Luckily, we have one randomized trial from Heidelberg, and they randomized prostate cancer patients to proton therapy or carbon ion therapy using 60 gray RBE in 20 fractions. And of course, both treatments were really, really safe, but the acute toxicity profiles using carbon ions were slightly better compared to protons. So probably this is the only randomized data we have till now. And so overall, proton is really safe in terms of toxicity for prostate cancer. And IMRT, using the modern techniques and modern treatment machines, the toxicity is very low, and it does not go up to 24 or 29%. But you can see still carbon ion therapy demonstrates really low toxicity and is very safe to treat prostate cancer. And this is a really important paper that was published in Lancet Oncology, and they compared the carbon ion therapy and surgery and photon radiotherapy in prostate cancer patients. The carbon ion therapy patients were treated in IRS, and using the Osaka registry, they had almost 2,000 photon radiotherapy patients and almost 6,000 prostatectomy patients. And you can see that the incidence of subsequent primary cancer is significantly low in using carbon ion compared to X-rays. And it's very interesting that carbon ions were the subsequent primary cancer incidence was even lower with carbon ions compared to surgery, but probably this was because maybe some the surgeons would probably follow with more cystoscopic or colonoscopic evaluation after treatment. So anyway, carbon ion had a significantly reduced second cancer risk compared to photons. And then now I'll share some clinical outcomes using carbon ion for prostate cancer. And mostly these important papers and reports were published by the Japanese group, which probably Professor Onishi has maybe participated in a lot of these studies. And you can see that the risk group does not really matter after carbon ion therapy, and the 5-year biochemical failure-free survival is over 90%. And the cause-specific survival using carbon ion therapy at 10 years is below 5%. So this is really important because according to the Capture registry in Europe, the 10-year prostate cancer specific mortality at 10 years is about 5%. So carbon ion therapy might be similar to prostatectomy in terms of 10-year cause-specific survival. So one interesting thing is that using photon IMRT, that high-risk patients tend to fail about 20 or 30% after 5 years. But using carbon, the 5-year biochemical control was over 90%. So this might be really important. And toxicity-wise, of course, there was no 5-year grade 3 toxicity, GI or GU. And the 5-year grade 2 toxicity profiles were really safe. You can see that GI toxicity was below 1%, and grade 2 or higher GU toxicity was very low with about 6%. And the J-Cross group has reduced the fraction numbers during the 30-year period since 1994. And they started with a 20 fraction scheme, and then they reduced it to 16 fractions, 12 fractions, and now probably 4 fractions in the future. And in Yonsei Cancer Center, we have adopted the 51.6 gray RBE in 12 fraction scheme. So using the current 51.6 gray RB 12 fraction scheme, they still have reported a very high 5-year biochemical control across all risk groups. For low risk, 95% and 91% for intermediate to high risk. And they have reported that there is no grade 3 or higher toxicity in the bowel or bladder or any genitourinary systems. And as far as I know, that they're testing a 4-fraction SBRT-like scheme in intermediate risk prostate cancer patients currently with a phase 2 study ongoing. And luckily, recently, a phase 1/2 study of ultra-hypofractionated carbon ion therapy for low to intermediate risk prostate cancer was published by the QST group. They have used 36 gray in 4 fractions, 40 gray in 4 fractions, and 44 gray in 4 fractions. Sorry for this typo here. And they treated 10 patients for each group, and they saw that using 44 gray in 4 fractions, it showed a quite high acute grade 2 GU toxicity with 50%. So they have recommended that probably 40 gray and 40 fractions might be the most recommended dose fractionation scheme when you treat the patient with a very short treatment scheme of 4 fractions. And this is in toxicity wise, this is a paper published from Gunma University. They evaluated the uroflowmetry and the prostate volume change after carbon ion, and they used the 16 fraction scheme for treatment. And you can see that the uroflowmetry, the maximal flow rate and the average flow rate and other flow rates can be reduced after 1 month after carbon ion, but after 3 months, they almost recovered to baseline level. And interestingly, the average flow rate even got better after carbon ion therapy after 3 months, 1 year, 2 year after carbon ion. And the prostate volume has decreased after carbon ion. And of course, as we can expect, when patients using ADT had a higher prostate volume reduction after carbon ion therapy. And this one is also a interesting paper from Gunma University. And they have compared prostatectomy and carbon ion therapy in terms of EPIC sexual score at post-treatment 1 and 2 years. And you can see that carbon ion therapy, which is in green, is much better in sexual performance-wise compared to radical prostatectomy, even they were all treated using the robot technique. And even you perform the nerve sparing technique. I'm not sure if you can see this very well, but the green is the nerve sparing prostatectomy. Still, carbon ion does better in terms of EPIC sexual score after treatment for these prostate cancer patients. And I'll go over the Yonsei Cancer Center protocol, and it's not really different from treating prostate cancer patients with IMRT or proton. And for all patients, we use the SpaceOAR hydrogel, and we insert 2 gold fiducial markers since we do not have a in-room CT in our fixed beam treatment room. And when we use a pelvic mold during simulation, and luckily we have a MR simulator in our department, so we do the CT and non-contrast CT and MR simulation in a single location. And we use the dose fractionation scheme of 51.6 gray RB in 12 fractions, which include 6 right beam fractions and 6 left beam fractions. And for the treatment planning, we use a robust optimization technique using RayStation, and of course the MKM model for our RBE calculation. And during treatment, since the prostate is highly movable depending on the bladder volume or any changes in the contents of the rectum, we use a follow evaluation CT after 3 or 5 fractions and see how much it changed from the baseline CT simulation images. So everybody might be familiar with the SpaceOAR hydrogel spacer, and there is a level 1 evidence regarding the efficacy of this technique. So in order to prevent rectal bleeding, we use this technique for every patient receiving carbon ion therapy. And like this on the CT image, we insert 2 fiducials in the right, one in the right and one in the left. And ideally, in the different level in the superior and inferior direction. So this is how you insert the SpaceOAR. So it only takes about 15 to 20 minutes inserting the SpaceOAR and the gold fiducials. Even for radiation oncologists, 15 to 20 minutes is enough. So for the planning technique, I will not go over the target contouring technique because everybody does it really similar. You just draw the whole prostate and include some of the proximal seminal vesicles if there is no invasion. After the CTV delineation, we do not use the PTV margin. Instead, we use this technique called robust optimization. And it includes about 16 scenarios, assuming the patient movement anterior, posterior, inferior, superior, and right or left, and the range uncertainty of 4%, since the distal part of the carbon might be not accurate. So using those all range uncertainty and possible setup errors, we evaluate the plan. I think you can't see this. There is a, it's called voxel-wise mean, and in the worst case scenario that even the patient's move, the setup is inaccurate in these directions, at least 95% of the prescribed dose will cover the CTV during treatment. So these are some of the dose constraints we are using at our institution. And since we are inserting 2 gold fiducials, there are concerns that there is a beam shadowing effect of the fiducial, despite it is about 1 to 2 millimeter in size. So if you use a single beam, then there will be a great beam shadowing effect of about 10% and a range shift of 5 millimeters. But since we do the bilateral beam technique, when we have measured the actual dose, then if you use the bilateral beams, then the beam shadowing effect will be under 5%, so it is quite safe. And so during the fiducial insertion, we do not want to insert the fiducials on the exact same beam pathway. So then the dose shadowing might be greater than expected. But however, anyway, using the bilateral beam compensation, then the dose reduction will not be significant. So this is how we set up the patient in the actual treatment room, and we do a auto registration for bone matching, and then we evaluate the fiducial locations, and we check how much the fiducial offset is, and then if it is larger than the margins we gave in when we did the robust optimization planning, then we do have to take a new CT simulation image and do adaptive planning for those patients. So about 20% of the patients needs reset up during treatment because of gas or maybe some bladder volume difference, or since the prostate is very highly movable, it can move anyway. So some patients needs to be set up again. And using relaxation or walking or Kegel exercise, then we can slightly move the prostate to where we want it to be. So these are the techniques we are using. And of course, for localized patients, we would offer carbon ion or IMRT or anything. But even in the metastatic setting, we know that primary radiotherapy can be beneficial in terms of survival. So, and even in high burden patients, which have very very high number of metastatic lesions, according to the recent PEACE-1 trial, that even in those patients, primary radiotherapy to the prostate can have a beneficial effect in terms of preventing serious genitourinary events. So I think we can expand the use and the indications of using carbon ion therapy for prostate cancer patients. So these are some patients we have treated, and you can see that there is a low ADC value lesion in the mid-level transitional zone. And after this is a MR sim image, which you can see the white spacer between the prostate and the rectum. And this is the planning image. And after treatment, you can see that the PSA levels has successfully decreased. And at last follow, probably this patient had a 0.1 or something like that. And this patient also had a mid-anterior transition zone, T2 low, ADC value low lesion on MRI. And you can see there is a suspicious extracapsular zone extension. And of course, he received ADT and carbon ion therapy. And this is the photo of the spacer and the planning image. And compared to the pre-CIRT MR image, you can see that on the post-CIRT 8-month MRI that the diffusion restricted lesion is gone on the MR image. So we treat prostate cancer patients in this way, but one of the most frequent questions in the clinic I get from my patients is that if I recur after carbon therapy, then is surgery impossible? But I know that most urologists across the world are very not wanting to perform prostatectomy after radiotherapy, but there are some reports from Japan that even after carbon therapy, prostatectomy can be done quite safely. Although there are, of course, you have to risk the incontinence after prostatectomy. And now for us radiation oncologists, after the post-RT failure in prostate cancer is the option. We have a lot of options after the failure, and it's not just ADT. And of course, I have mentioned that prostatectomy is an option, and there is cryotherapy, HIFU, and some reports of SBRT, and of course, re-radiation using brachytherapy can be quite successful. So we can use these options for recurrent patients. And I'll just go over shortly of the future directions. And one of my most concerns in the clinic is that we have done so much advertisements that carbon therapy is really good. So a lot of patients in Korea just come to our clinic that they don't want surgery and they just want carbon therapy. But I think it's really important to identify the most optimal patient group that can have a large benefit using carbon instead of X-rays, because most patients, even in the high risk, about half of the patients can be treated successfully even with IMRT. So I believe that we don't have to do carbon for every prostate cancer patient, but it is really important to identify the most optimal indication for carbon using these genomic biomarkers. Of course, everybody will be familiar with the GARD radiosensitivity score and some prostate cancer specific genetic radio models, prognosticators after radiation. Of course, the most famous one is Decipher, and it has been validated in a lot of radiotherapy patients. And there is the PORTOS, which can predict. This PORTOS was developed using the data from Decipher, but it is more dedicated to radiation response. So using these kind of validated genomic features, I think we can choose more optimal patient groups for carbon in the future. And technique-wise, I think this is a ongoing and hot project in Japan, that if you actually give more high LET in the GTV, then the tumor control will go up. So this is an example of pancreatic cancer, and you can see that the RBE dose distribution shows that the high dose is concentrated around the actual CTV we want to treat. But if you look at the actual LET, then you can see that instead of the GTV, the high LET area is on the outside of the CTV on the distal parts of the beam. So it would be ideal that if we can concentrate the high LET to the actual GTV. And it has been reported that the GTV LET matters in terms of tumor control. And now you can perform the LET patenting technique to improve the outcomes of carbon-ion therapy. You can see that if you do the LET optimization on the graph on the right side, you can see that you can actually concentrate the high LET in the GTV. So to summarize my talk, carbon-ion therapy results in excellent biochemical control and a very low and safe toxicity profile in prostate cancer. And of course, since there are very many things you have to concern when performing carbon-ion therapy, such as the dose reduction effect by the gold fiducials or the rectal spacer and some planning techniques. And although I didn't show the data because we are currently under the post-marketing surveillance of this carbon-ion machine in Korea, but in my experience, I experienced a quite higher acute grade 1 or 2 GU toxicity compared to the 20 or 28 grade IMRT, but I think it was really comparable to the SBRT patients I have treated. And we did not observe any, of course, no grade 3 or higher toxicity in the acute phase, although we need longer follow-up. And thanks to the Japanese group, we now have a evidence of efficacy and safety data from the SBRT-like regimens using carbon-ion therapy. And although this also has to be needs longer follow-up, and probably moving forward, we can reduce the fraction numbers for these patients. And one more thing I didn't mention in this talk is the use of whole pelvic radiation. And probably you all know that in high-risk patients, there are now even level 1 evidence that pelvic radiation can improve disease control, probably not overall survival, but probably nearly all of the other outcomes, especially in high-risk patients. But we are now using a prostate-only treatment technique using carbon-ion. So we have to consider how to use the pelvic radiation techniques for these patients treated with carbon-ion. And and the Italian group in CNAO is now, as far as I know, testing pelvic radiation with photons following a prostate boost using carbon-ion. So I think these clinical trials will give us some more hints to how to use whole pelvic radiation in these patients. And of course, in prostate cancer, now so many drugs are approved in those high-risk patients. So how we can combine the pelvic radiation with those drugs will be really important issue we have to concern about. Thank you for your attention.
Thank you, Dr. Wee, for your comprehensive review and sharing your experience with carbon-ion to manage prostate cancer. So I think we are open for discussion and some questions. So firstly, I want to ask our fellow panelists for their generalized opinion regarding the application of carbon-ion for prostate cancer. So may I ask first from Dr. Zhang Qing? Dr. Zhang, you are still muted.
Yes, I'm here. Thank you.
Okay, thank you. So I'm just I'm going to ask first some general brief comments from our three panelists. I will open the floor for the questions. So, Dr. Zhang, any idea or comments?
Oh, okay. Thank you for the invitation from the organizations, and that's really an excellent talk, and we really learn a lot. And we also really appreciate from the help from the QST and GUMA, and they really help us for a lot. And I'm from Shanghai Proton and Heavy Ion Cancer Center, and right now we only have 10 years experience for prostate cancer of carbon ion radiotherapy. And to our knowledge, right now we using do not use fiducial, and we use in-room CT to do the positioning and confirm and before every treatment. And one important thing we learn from our treatment is the different biological model between the different facilities. Since first of at the beginning of the treatment, we use 60 the almost the same dose as IPI HIT model. But we really found that the toxicity is lower, but as they mentioned, the biochemical free survival is lower and actually different from the proton. So we set up some data to compare the different between the different biological model. And since we right now we use the Siemens facility, and Japan right now use the biological model is a LAM model, and that's different from the MKM model. So if we use the same dose, we found that the biochemical free survival is pretty low. So we set up the dose escalation data to confirm to optimize the dose, and found that we need to use the 4.1 GY-RBE dose per fractions for the 16 fraction size treatment, and to use the 4.9 GY-RBE dose to in the 12 fraction size treatment. So right now we use that's pretty different from the MKM model, so we think that's really important to mention that we need to pay attention to the different biological model between the different facilities, and we also concerned about the really like the presenter and talk before, and is the recurrence after how to choose the recurrence after carbon ion radiotherapy, and also to how to choose the optimize patient to treat prostate cancer using carbon ion. That's really is also our concern, and we need thanks on the presenter to give us the talk, and we need to learn. Let us to learn more, and thank you.
Okay, thank you, Dr. Zhang, for your acute comment on the complicated issue regarding the optimal biological model to compute radiation plans. So it's very crucial to compare data from different institutions. Dr. Lee, do you have any, are there any program ongoing in your institution to review or revise your biological model in your treatment planning now, or you're just is your model just fixed for the time being?
Currently, we do not have any ongoing project to address those issues, and we just, I think we need a few more years to build our learning curve in prostate cancer. So we just adopted the Japanese protocol from QST, Gunma, and other institutions.
Yeah, thank you. So I'm going to switch to Dr. Onishi Sensei. Could you just provide some general comments on the present talk and some insights from your own experience?
Thank you. My name is Masahiro Onishi. I'm a judge of CIRT for genitourinary tumors at Gunma University. It's a great honor for me to participate in this meeting today. Our institute, just wait one moment. So at our institution, we had not previously recommended aggressive salvage treatment for local recurrence after heavy CIRT. However, in recent years, robot-assisted laparoscopic surgery have become more widely performed across Japan, and salvage prostatectomy even after prior CIRT. Outcomes from high volume experience centers suggest that salvage surgery is feasible and can achieve favorable results. Therefore, in current practice, for patients who experience local recurrence after CIRT are still on the operable age and condition, we present a range of salvage options. Yeah.
Okay. Yeah, thank you. So now finally I want to switch to Dr. Lee, Sung Lee, for his comment on the current issue and his own experience with the particle beam treatment.
I'm very honored to being a panel in this great symposium, and I'd like to express congratulations on the birth of Dr. Lee's baby. And actually, I have only experience on proton beam therapy for prostate cancer, and given the very sharp penumbra of particle beam, especially actually the sharper in the carbon ion beam. We also do a CDV-based plan. It is very hard to confirm the safe serum margin uncertainty coverage in the treatment planning, and we also very concerned a lot for accurate dose delivery for the patient. So I'd like to ask Dr. Lee about his how do you check those safe dose coverage of carbon ion beam in treatment planning, even to not use a PDV margin, and what is your preference in safe serum margin in prostate cancer patient in carbon ion beam therapy?
Okay, so thank you for your comment, Dr. Lee, and we also asked one question directed to Dr. Lee regarding the practical issues of PTV margin or any planning issues to safeguard the accurate treatment. Dr. Lee, could you give us an answer?
Yes, thank you for the great question. And of course, since the prostate is very movable, I'm always concerned about those margins. But we have a very accurate bone matching system, and we can check the fiducial offsets in 1 or 2 millimeter distance. So regarding the margins, we use a margin of right and left 1 cm and superior inferior 5 millimeters, and anterior, I think it varies among radiation oncologists in our institution, but we use 5 to 7 millimeters, and posteriorly we use 3 millimeters. And as I showed very briefly about our robust optimization technique, and it shows the voxel-wise minimum dose delivered to the patient when even the patient moves in all those scenarios. Of course, for each fraction, still the 95% of the prescribed dose will cover the CTV because the stopping power of the materials in the carbon ion beam pathway will affect the dose delivery. We assume that the bone and the muscles will move in those margin range. So even though the patients have moved a little bit and there is a setup error, the CTV will still be receiving over 95% of the prescribed dose. I'm not sure if I explained it very well because my short English, but was it enough?
I assume that Dr. Lee is satisfied, judging from his.
Yes, thank you.
So thank you all panelists, 3 panelists. I appreciate your valuable comments and contribution. So now we are open for questions from the floor or online. So firstly, I want to cover collective questions first. We have 4 questions so far, and I think one of the questions is quite relevant to the PTV issue. So Dr. Bo Zhao asked regarding the planning issue. So he asks about the how to assume setup error values for 6 directions for robust optimization. So he's actually asking about the more detail about robust optimization and the assumed scenarios. Okay. So Dr. Lee, could you explain more in detail regarding the assumptions and the practical actual numbers regarding the robust optimization?
Yes. Regarding the margins for the robust optimization, as I explained, is laterally 1 cm and AP 3 to 5 or 7 millimeters and SI direction 5 millimeters. And if the bladder dose is too high in some patients, then we can reduce the superior margin a little bit. And of course, there are a lot of uncertainties we are concerned about when treating prostate patients, but it's not really different with IMRT or maybe proton because all that matters is how much the prostate moved or how much the bladder is filled and what is in the rectum. Is there a lot of gas or any stool content? So it's not really different from conventional radiotherapy. So we can check check the amount of the gas in the rectum. Of course, it's not really accurate through the x-rays we take in the treatment room. So if the patient has a lot of gas and then we perform enema or some techniques widely used for any radiation technique for prostate cancer.
Okay, thank you for your clarification. So I don't have any first-hand experience with particle beam treatment, but unlike the BTD margin for photon treatment, the particle beam treatment is further complicated with the different stopping powers associated with the zeta level. So that is the fundamental assumption or rationale for stop treatment. So, thank you. And next question is very simple. Is the carbon treatment covered by national medical insurance system? So
it's not currently covered by the medical national insurance system.
So that depends on the jurisdiction and country to country. So I will go to the next question. Actually, one asked about the elective nodal irradiation for carbon treatment, but Dr. Yi already mentioned that he does not do any elective nodal irradiation carbon treatment, irrespective of the rationale or not. But this is the situation. So I will skip the question. And okay, the one question is quite interesting. So Dr. Ciari asked about the relationship, the influence of high LET radiation on immune cells within tumor tissues. So, so he asked about the maybe low LET or low doses around the target volume might be beneficial to induce the immune reaction. So that is his question. So, so there are burgeoning, very active research into that issue, the relationship between radiation and immune response. But Dr. Wee, do you have any knowledge regarding the relationship between high LET radiation and immune reaction?
Actually, I'm not sure. I'm not a immune guy, so I'm not sure about that. I can't give you a answer for this question, but there are in vitro studies that show that the high LET and the higher cell killing might be more beneficial in provoking the immune reaction to the tumor cells, but it's totally different in the actual patient's prostate and the microenvironment surrounding the prostate. So I'm not sure how it will work around the actual prostate. Sorry.
Sorry for asking difficult questions. So several years ago, I came across interesting research, in vitro research regarding the high LET versus photon radiation and the immune reaction. They used the proton treatment like carbon, but there is some evidence that proton is more effective in reducing immune reaction compared to photon. But for carbon treatment, nobody knows. There's a quite large room for further research. So I will switch to the next, the final question. It's a question about the comparison between brachytherapy and carbon ion treatment. So the questioners argued that the brachytherapy requires no PTB margin, zero PTB tolerance, because it's just interstitial treatment. However, a carbon ion needs quite large margin of PTB or robust optimization to ensure the adequate dose delivery to intended target volume. So he's asking about asking whether carbon ion is really superior to brachytherapy. So what is your opinion, Dr. Yu?
I'm not sure at this time point that I can answer this question, and I'm not sure if anybody can, but I know that brachytherapy is a really, really excellent treatment option for prostate cancer patients, but I don't think I can compare it. I don't have any data comparing the outcomes, but still, the reports from Japan and other countries show that the biochemical control using carbons are really high and the toxicity is really low. So in the clinical viewpoint, I think it might be comparable or still I acknowledge that brachytherapy is a really good option for prostate cancer patients that needs to be more performed in the clinic.
Okay, thank you for your answer. Actually, this question is quite complicated issue because zero or little PTB margin is just only one constituent for quality radiation. There are a lot more factors to be considered to deliver optimal radiation. And the final question is, he's asking, is there any dietary modification strategy, dietary modification or any medication, drugs, whatever, to improve reproducibility of vector positioning or volume control? Are you experienced, Dr. Lee?
I think this is a very practical question, and every clinicians may have a different answer for this, but I don't like to restrict anything from my patients, so I don't have a actual dietary modification, but I give them some medications used for constipation so they can have their gases out and they go and defecate almost every day, but there are a lot of cases that those medications don't work for the reproducibility. So in those patients who always have a lot of gas, then we just do the enema for those patients.
Yeah, thank you. So since I think virtually all of Dr. Wee's patients has received the space OAR application. So the variable rectal volume and positional sensitivity might be little concern for him to planning radiation. Okay, I've got a new question. So he's asking about the how to compare cost and toxicity between the among SBLT and proton treatment versus carbon ion. So regarding toxicity, Dr. We already mentioned that the carbon ion apparently shows superior, or at least a comparable or some superior toxicity profile compared to SBLT and protons. So Dr. Could you add some your insight for cost thing? Regarding in comparison with the SBLT and proton?
Since it's not covered by the national health insurance in Korea, of course, I think carbon ion therapy for prostate cancer patients, cost-wise, is not really maybe not very proper, but if the cost goes quite lower than I think it might be comparable to SBRT or other treatments. But as I showed in my slide, that even with those high dose 8 gray 5 fractions SBRT, although we do not know whether those prostate cancer cells found in the biopsy specimen is viable cancer cells, but we still see those cancer cells in the biopsy specimen after SBRT. So in some of those cancer cells, which can be really hypoxic or quite radioresistant, then there might be some room for carbon ions to help to kill probably a small portion, but those radio-resistant cancer cells. So of course, ideally, we need a randomized trial comparing SBRT and carbon ion or protons, but I'm not sure it can happen in the future not sure anywhere. So we just have to rely on the reported data to date.
Thank you for answering the difficult question. Actually, the questions regarding cost is basically actually the question regarding cost effectiveness. But the actual clinical superiority of carbon ion has not been fully proven in high quality evidence, so further complicated the issues of cost effectiveness. So now I covered all the questions from chat window. So are there, if anyone have questions, please submit the questions in chat. So, okay, so that I can deliver them to Dr. Lee. So while we are waiting for questions, are there any comments from panelists, 3 panelists here?
I think my explanation on the robust optimization and the margins were quite not enough. So I want to add some words to that. So in the treatment room, we always, for me, I always treat the patients where the fiducials are exactly matched with the images from the reconstructed DRR images from the planning CT. So that's actually where the prostate might be with a very high chance. But even we actually match the fiducials, then the patient muscles and the bones might be quite different from the planning CT. So the allowed margin for that setup difference, of course, we do not know how exactly the waters or muscles will be, but assuming those will move with the bones. So I match the fiducials, and if the bones are within the margin we used for robust optimization, then we assume that at least 95% of the prescribed dose will cover the CTV, so we can treat the patient safely in terms of the CTV coverage.
Thank you. Regarding that issue, I have one question to Dr. Onishi. Dr. Onishi, what is your image guidance device in your carbon ion machine for prostate treatment? Do you use a fiducial or do you have in-room scan, CAT scan? Dr. Onishi, you are still muted. You should unmute yourself first. Okay.
Okay. In our institute, we don't use physical marker. But I think we should use physical marker, and
So how do you set
sorry.
up your patient? So to use a CT scan?
No, we only matching bone matching, but we
Okay.
I think we
Okay.
need physical marker or CT matching.
Okay, thank you. So how about Dr. Zhang?
In our facility, we use in-room CT to check the positions. Since we found that the position immobilization is quite important. Since first, at the beginning of the treatment, we use a 2D pot film to check the muscle and the bone match to do the bone match. Recently, we use the in-room CT to do the position checking, and we also do the bladder preparation and rectum preparation before every treatment. But for the PTV margin, and we right now for the bladder part, I asked my student to do some analysis and found that 4 millimeters is maybe is better than 3 millimeters. And for the rectum part, we use 3 millimeters to margin. And for the lateral margin, our physicists to use a formula to set up the lateral margin, and I think maybe around 1 cm to 1.2 cm, since the femur head moving is quite will quite influence the dose distribution. Thank you.
Okay, thank you, Dr. Zhang. So finally, Dr. Lee, do you have any comment on your practice for imaging guidance for prostate?
Yeah, thank you.
Center?
In our center proton beam therapy facility, there is a cone beam city is installed in treatment room, so we can make a patient setup as same as SBRT in lineup machine. So I usually check cone beam city for every fraction, and actually we found that there is a lot of motion in prostate, and especially caused by a rectal volume change, things like that. So we generate new treatment protocol as like SBRT for proton beam therapy. So we insert a space OAR between rectum and prostate, and we reduce the number of fraction of proton beam therapy as a 5 fraction, and then we every day check a cone beam CT scan, and if there is a rectal reproducibility is not good, we do everyday enema for that patient. We expect we can achieve the best reproducibility by doing that, because we reduce the number of treatment, because if the number of fraction is so long, we cannot there is a I think very some side effect of frequent enema for total treatment. If I do everyday enema for 20 or 3 fractions, so I think it is relatively safe if we do frequent enema for the 5 fractions. So but using those process, we achieve excellent reproducibility. So as I know, there is no cone-beam CT scan system in carbon ion beam therapy. So that is why I asked the serum margin in the previous question.
Okay, thank you for sharing your experience. So I'm not sure how much more time I'm allowed to hear, so I'm just ready somebody to stop me now. So
I think I noticed some questions regarding the intrafractional motion of the prostate, which is also a concern for me. But some patients with quite poor compliance, we have taken pre-treatment image and the post-treatment image, and the distance between the fiducials between those two images, normally 1 or 2 millimeters. So since the treatment time for carbon therapy is around 1 to 2 minutes, it's very short. So I don't really concern it now, but of course it's always a concern for some patients that have poor compliance, and we educate the patient not to force their anus or tell them to tell us before the treatment if they have such a full bladder, so they cannot relax on the treatment room. So I think if we have a cone-beam CT in our treatment facility, it will be the best using fiducials and the cone-beam CT. But for now, I think we are doing quite enough, maybe. Thank you for the questions.
thank you. So there's many questions focused directed to the issues of PTV and image guidance practice, because in my personal opinion, carbon ion treatment is lagging behind in the area of image guidance, in image guidance, because the construction issues of the massive carbon ion machinery is rather complicated with the instrument of the further complex, sophisticated image devices. So I think we have covered all the questions submitted. So it's it's 1.5 hour symposium tonight. So is there any questions? So I think may I close the session now? So can I? Okay, so thank you, Dr. Lee and Dr. Wee, and congratulations on your daughter's birth. And okay, thank you for all participants, and especially our valued 3 panelists for their valuable comments. So it is quite my honor myself to be a moderator for this valuable session. Thank you for all. Have a good night or good morning, whatever. I wish you every luck and good health. Bye.
Thank you.
Bye.
Thank
Thank
you.
you.